Good afternoon, everyone. On behalf of the Priority Consult team, I would like to welcome everyone to the Spine webinar series. Today we will be discussing the collection of clinical outcomes data within a spine center. My name is Holly Groneck. I am part of the Priority Consult team, and I will be speaking today along with Karen Lewis, who is a nurse navigator at the Integrated Spine Center at Pardee Hospital. So just a little bit about myself. I am the Client Relations Manager at Priority Consult. I joined Priority Consult in 2010, and I have worked on spine center development, specifically establishing clinical outcomes, intake, and navigation programs for our clients. So I'd like to start off today by addressing why it is important to collect clinical outcomes. So first, outcomes data is often used to validate treatment effectiveness, which then can be used to improve care delivery protocols, which all will result in better care for the patient. Outcomes data and results can also be used in marketing efforts to market the success and quality in the care provided. And last, with the pay-for-performance movement, outcomes data will be becoming increasingly important as different payer programs, especially Blue Cross and Blue Shield, will likely require outcomes data when reimbursement becomes tied more to outcomes and performance. So I want to discuss a little bit about our approach to the outcomes collection development. We began in 2007 talking to clients and other industry leaders to get feedback for what needed to go into an outcomes program. So over a 2-year period, we worked with our clients specifically by setting up pilot programs at Salem Medical Center and Inova Health System. We began experimenting with the methodology of outcomes collection, and then we updated our software accordingly. So in May of 2010, the protocols and documentation have been completed, so we made those available to all of our clients who were interested in the outcomes collection program within their organization. So as of today, we have about 15 spine centers who are collecting clinical outcomes, and they use their outcomes data to share their results with one another, to benchmark and talk about process and improvement. In our discussion today, I am going to address the 4 questions that new organizations need to answer when beginning an outcomes collection program. So you'll see, the what, who, when, how of outcomes. So what metrics are most likely to serve as the standards for clinical performance? We'll definitely get into the surveys that we provide in our software for our clients to collect. We'll also talk about who are the appropriate populations for the outcomes data collection. So which type of patients should outcomes be collected for? Then we'll get into the time frame or the collection intervals that should be used for collecting outcomes data. So when in the treatment continuum should you start collecting clinical performance outcomes measures? And then last, we'll talk about how to collect the greatest, the best sample of data that you possibly can. So the first question is what to collect. So the following 4 goals listed on this screen will help to better understand what you should look for in the data. So data that serves a purpose. It needs to be descriptive and predictive, and also you want to be able to measure change. You want to be able to measure that the outcome has either improved or gotten worse. So purpose is really important in the data that you collect. You also want to make sure that the data you're collecting is valid. So are you collecting from the population that needs to be collected and is it accepted within the industry. You want to make sure that the outcomes collection is feasible. So administration can be easy, and your users can get this information easily. And then last, you want to make sure that the data that you're gathering is gathered in a cost-effective way. So let's talk a little bit about the surveys that some of our clients utilize. So there are 5 surveys that are built into the Priority Consult software, which our clients will utilize. These are the Westry Back Pain Disability, the Neck Disability Index, the Pain Scale, Goals and Satisfaction, and then the PHQ-9. And we'll definitely take a little bit more in-depth look as we move along. So first, let's talk about the Westry Pain Disability Questionnaire. You can see just 2 questions that we've highlighted here, but the questionnaire actually has 10 questions which address pain and functionality. Each question is answered with one selection that will best describe a patient's symptoms. So after the 10 questions are completed, a score will be calculated, and we will talk more about how the questionnaire is scored later in the presentation. The next survey that we'll take a look at is the Neck Disability Index. So this is basically the same questionnaire as Westry, but it focuses more on the neck. So it is also a 10-question questionnaire related to pain and functionality, but you will notice that some of the questions deal more with pain specific to the neck. The next survey is the Numeric Pain Rating Scale. So there are actually 2 forms that go along with the Numeric Pain Rating Scale. One is focused on back and leg pain, and one is focused on neck and arm pain. So this is used to identify where the pain level is for a patient. So a patient would be asked to rate their pain on a scale of 0 to 10, with 0 being no pain, 10 being the worst imaginable pain. And then this information can be used from each interval to see if the patient's pain is getting worse or better. The next questionnaire is the Goals and Satisfaction Questionnaire. So this was actually developed by our team of clients who comprise our Outcomes Task Force team. So this group of users developed questions that they wanted to ask to measure satisfaction from a patient. So you can see there are 7 questions that will be answered by a patient. It's just a scale of 1 to 5. And there's also 3 questions that patients can put in their comments related to their satisfaction. So this has been accepted and used by many of our clients who are collecting outcomes. So eventually these results can be used to benchmark with one another. And finally, we will talk about the PHQ-9. The PHQ-9 is the Patient Health Questionnaire. This is a depression rating scale. So there's 9 questions that will be answered on a 0 to 3 scale, which would then be totaled, just the answers added up, and the final total would determine their depression rating. So the scores are calculated, and if a patient falls into a score of 1 to 4, they would be considered to have minimal depression. So then 5 to 9 would be mild depression, 10 to 14 would be moderate depression. When you reach a score of 15, you're getting into the moderate severe depression, and then 20 to 27 would be severe. So if a patient does answer, in this 15 to 27 range, you probably take next steps to help manage this patient's depression. So that would become very important in the patient's treatment process. So we're going to look a little bit deeper into the Oswestry questionnaire. So you can see that this is just one question on the questionnaire, and the category is pain intensity. So the patient will have 5 answers to select from to best describe the category that is in question. So you can see each question would then have a numeric rating for that question, and then at the end these questions would all be added together. So when scoring the Oswestry neck disability in the Priority Consult software, it's automatically calculated. So if the answer is inputted, a score is then calculated based on the answer. So there are 10 questions, each with 0 to 5 score. So the maximum score would be 50. So once this is added together, it would be multiplied by 2, which would then produce a percentage score. So you can see the degree of disability depending on the percentage of that is calculated from this. If a question is not answered in this questionnaire, it will automatically be calculated just based on the number of questions answered. So this is an automatic calculation as well in the software. All right, now let's move into the question of who. So which patients should have outcomes collected for them? We recommend collecting outcomes for both surgical and non-surgical patients who have received conservative care. And some of our clients have even taken it a step further and broken down their patient population to collect from a specific insurance provider or payer. A couple examples would be Blue Cross and workers' compensation. And we have also had clients who have looked at a specific company, the employees that come from that company, to see and report on the data for their outcomes. So the data can then be taken directly to the payers or the employers in either of these cases, and the outcomes for their patients can be reviewed. So now let's talk about when outcomes should be collected. So we have worked with many clients to develop a specific collection interval protocol. Clients can choose to leave specific intervals out of the collection timeframes, but the benchmark intervals that have been set are on this screen. So you can see for surgical patients, we recommend collecting an initial outcomes at pre-op, and then again at the post-op 1 month, 3 months, 6 months, 12 months, and 24-month time frames. So every time that outcomes is collected at these time frames, the results can be evaluated to see how the patient is doing. And then on the non-surgical side, we recommend a baseline initial collection, and then again at 1 month, 3 months, 6 months, 12, and 24 months. So again, this is our recommendation, and this is what is used to benchmark, but organizations do have the opportunity to decide how they want to collect. All right, so one of the hardest questions that I think to answer in an organization is how to collect outcomes. So when an organization is just starting out collecting outcomes, they may attempt different processes to figure out what is best. So it's very normal to go through a trial and error type process. You need to figure out what works best for you, what works best for your patients, and how you can get the most results that you can. So there are staff-driven methods, which would be in the office, so at the appointment collecting outcomes from the patient, or through mailing forms to the patient, and last through phone calls. Phone calls can be, a little bit harder because if you remember in the Oswestry and the neck disability forms, a patient needs to see all 5 answers in order to select which answer best describes their symptoms. So it's kind of, trial and error to see which of these 3 staff-driven methods would work best for you. There also is patient-driven methods, so through handheld devices or secure patient portals. So handheld devices could be a laptop, an iPad, anything that you would provide in that appointment that a patient could log in and fill out their outcomes forms. The secure patient portal is actually offered through our software where a patient registers and sets up an account so that they can go into their account and fill out their outcomes forms as they become available. So this is an example of one hospital and their varying collection methods. You can see also that at each interval you may find that you use a different method, which is shown through this example. So at the initial appointment, 95 patients were actually asked in person to collect their outcomes. As you go along in the intervals, you can see this number quickly dropping, and actually the mail form increases. So you can definitely see that it depends on your patients, it depends on the interval to see which collection method is most successful. And this report will show it also an example of one organization's response rate. So you can see that each month this data is reported. So 55, in June of 2008, 55 patients had been created in the software. 34 of those patients had an initial outcomes entered. 18 had a follow-up interval entered. And then of those 18, it was the 6 months outcomes. So for the response rate for the initial outcomes, it was 61.8%. And then for the follow-up, it was 32.7%. So you can see in this example that the collection rates range from 34% to 63% for the initial collection. And then for follow-up, it's 9% to 33%. And then this is another report that demonstrates collection rates. So you can see that for this organization at pre-op, so at the initial collection, they achieved an 88.5% response rate for outcomes. And you can see that this number definitely decreases as you move along in the interval, but still this is very strong, collection rates for this organization. And then this report actually will show 6 different organizations and their response rates. One thing I do want to point out, our clients work towards achieving an 80% response rate at each interval. This is, a very high rate, but it's a goal that was set, and, based on some reviews that were completed, it was the number that most organizations do try to reach for their collections. One thing just to note out in this report, for the 1 month, you can see a few organizations actually only had a 1% collection rate, and that is probably because they're not collecting at 1 month. So that goes back to the when of the question of when the collection should be done. So these organizations may have opted out of the 1 month collection and moved just to the 3 months. So as we began reporting improvement in Oswestry and neck disability scores, it was really important to define what improvement means. So this led our outcomes task force to take a look at MCID between each interval. MCID stands for Minimal Clinically Important Difference. And when discussing MCID, it was important to conduct literature reviews. So many of our clients and our team researched this to find what it truly meant to improve. So what we have defined is that an oswestry score improvement is considered when there's a 6 percentage point difference in the overall score. And for the NDI score, it's considered an improvement when there's a 7 percentage point difference in the overall score. For example, at an initial collection, a patient may score 50% for their oswestry score, and this is considered to be a severe disability. At 3 months, when the outcomes is collected again, this patient may score 44% on their oswestry form. So this would be considered an improvement in their disability, and they would actually then fall into the moderate range. So the next graph that you see here is an example of improvement rate benchmarking. So you can see that improvement in score is marked as a decreasing score from interval to interval. So all 4 of these hospitals did see an improvement from the initial to the 1 month, 3 months, 6 months, 12, and 24. So that's the curve that you're looking for in your reports, just to show that there is an improvement being made from each interval. This report compares 6 different hospitals as well and their improvement rates. So you can see the scores vary, but most hospitals did see an improvement in scores among patients. So this is just showing a graph of each hospital and how many patients improved, what the percentage was for those patients, and then how many patients stayed the same, and then those that got worse. So one common denominator in a successful outcomes program is an operational champion. This is often a registered nurse. It could be anybody within your program that can provide oversight to the outcomes program. And some responsibilities that this person will be to perform regular audits for verification and compliance, to use data collection to perform statistical analysis. They can even set up and use a data management system. So how are they going to collect the data and use the data then? And then last, to train new physicians and staff on the outcomes process and the outcomes tools. One way that Priority Consult helps these operational champions in their audits is by providing a Audit Q. So this is a screenshot that shows what users can use to see when a survey is maybe outside of the acceptable time frame. So this would highlight in red any patient whose actual collection date is outside of the 2-week window for the due date that was actually set. The software does allow you to enter data outside of the 2-week interval, but you can use this specific queue to identify any issues, which you can then choose to fix if it is a problem, or maybe it was just an issue with the date inputted, and then that can be resolved as well. Often, spine accreditations will require outcomes collection, and some of our clients have achieved Blue Cross Blue Shield Center of Distinction, and they've used the data that they've recorded in Priority Consult to achieve this accreditation. So I've highlighted here a few requirements that have been used for accreditation. First, the Blue Cross Blue Shield Center of Distinction will require functional outcomes to be collected routinely, so both pre-op and post-operatively, and it can be through the oswestry disability, the neck disability, the SF-36, any functional outcomes form that you choose. The second item would be to collect functional outcomes for 12 months following the start of the treatment or the date of the surgery in at least 11% of patients. And then last, organizations will need to record rates of surgical complications, reoperations, hospital readmissions, length of stay, and discharge dispositions. And at least 69% of patients who are admitted from home need to be discharged back to their home. So all of these items can be recorded within Priority Consult, and then reports can be generated from the data and can be used to achieve an accreditation. So your outcomes initiative is really up to you. You can use outcomes to achieve anything that you want to achieve. So you could use outcomes as a single data gathering process that you use among your organization. You could use outcomes to build a database and analyze these results for future care. You could also communicate the results quickly to providers, patients, and payers so that they can see the results that you are seeing within your organization. These results can be used to improve patient care that is provided. And then last, you can market this improved patient care and the quality outcomes that you have collected to the general public as well as your local physicians and referring physicians. So I'm now going to introduce Karen Lewis, who is our next speaker. Karen is the spine navigator at the Integrated Spine Center at Pardee Hospital in Hendersonville, North Carolina. Karen has her master's degree in nursing and has family nurse practitioner training from the University of Washington in Seattle. She has had 7 years of neurosurgery experience, and as a nurse practitioner spine navigator, Karen evaluates and guides patients to the best avenue of spine care. She serves as the point of contact for patients and their families, and also has been working on the outcomes program there. So Karen, I will now turn it over to you.
Thank you very much, Holly, and thank you for everybody who is tuning into this webinar. And I'd like to start off by saying that the fact that I'm speaking does not mean I'm an expert whatsoever in outcomes collection, but I'm here to tell you about how we started our program. And I'd like to stress from the beginning that we are a very new program. I was hired about a year ago and spent many months coming up with our policies and how we were going to do things. But we did not even open for a trial until November of 2012. The trial was limited to certain physician practices, especially those that were associated with the Spine Center. And then about a month later, we opened full-fledged to other practices in the community. So, so just again to let you know, we are very new at this. I was extremely lucky, however, in that I had 2 very experienced administrative personnel who had both developed spine centers and were familiar with outcomes collection. One was Chris Peters. She started a spine center in Woodruff, South Carolina, and was familiar with Priority Consult, as well as Jim Bloodworth, who came on as our service line director after starting a spine center in Salem, Oregon. So that's that key point is if you have some administrative support, really helps. But the reason we are collecting outcomes is because Pardee Hospital really had not been collecting many outcomes, and so the administration was really pushing for the Spine Center to be one of the first service lines to collect outcomes. And this service line was to be a model for all other programs in the hospital. And in developing this webinar, I realized that other spine centers may have the luxury of bringing the outcomes portion of this on later. I didn't. I knew from the beginning that I had to start collecting this with the very first patient. Okay. So a little bit more about us. We've received an average of 58 referrals per month since January of 2013. Over 200 referrals have been received, and right now 150 patients are part of the outcomes collection program. Okay. So what I'm going to tell you about with our experience is how we planned this whole thing, the many challenges we incurred, give you a sample of some of our non-surgical and surgical data, and then also talk about our future plans. Okay, and I kind of discussed this a minute ago, but why outcomes? And that is mainly because I was really pushed to do this from the beginning. The hospital was wanting to make sure this is a service line that other service lines in the hospital can be modeled after, and they are really pushing towards us becoming an accountable care organization. Okay, so I knew I had to collect outcomes, but where did I start and what did we collect? And as I said before, I've been clinical for many years, had a lot of neurosurgery experience, assisted in neurosurgery in the operating room, but really had no idea about outcomes. So again, I was lucky in that I had administrative support that were familiar with some of the surveys out there. And interestingly, one of our pain management physicians that is part of our spine center really championed this program. He knew also about some of the available outcomes. So at one of our monthly meetings this summer when we were getting started, we basically printed out these surveys and passed them around to the team, and pretty much everybody decided that that was on the ones that we are going to use, which I think are shown on the next slide. Yes. And so Priority Consult was also extremely helpful because they had most of these already in their database, and Holly did a great job explaining the ones that are available on Priority Consult, and we ultimately did decide to go with the Oswestry, the Neck Disability Index, the Numeric Pain Rating Scale, and the Goals and Satisfaction Survey. And then we use the PHQ-9 for any of our patients that are going to be undergoing surgery. But also in our research on surveys, we came across one additional one that we decided to use, and that is called the Ottawa Personal Decision Guide. And this is one we use when we encounter a patient that is having trouble deciding on whether or not they want to proceed with an intervention. And this may be a surgical intervention, or it could be something like an epidural steroid injection. Once we receive these surveys, we do enter them into Priority Consults, and I'll speak a little bit about that in a minute. But the next slide, I think, gives us a snapshot of what the Ottawa Personal Decision Guide is. And as you can see, it's not necessarily just for medical purposes. It can help people decide on many things in their life. But interestingly, based on its name, the owners and the people that produce this are in Ottawa, Canada. And so my spine intake specialist, who was very integral in helping me get this started, took it upon herself to find out their contact information and actually emailed Canada to ask for permission. And within a day, they got back to us and allowed us to use it. So if anybody else out there is interested in this, I'd be happy to give you their contact info, and hopefully you would have the same experience. All right, and the other thing we are collecting, and as many of you know by getting the monthly reports on your spine center from Priority Consult, that pretty much any of your intake data can be collected and then used for other treatments down the line, or other purposes down the line. And so we are collecting things such as patient demographics, their occupation, their diagnosis, and current work status. But it's also nice to know that, that based on the flexibility of Priority Consult, that we could customize this even further as we go along. So we are, as I mentioned, trying to be an accountable care organization and hopefully going to pursue a Blue Cross Center of Distinction. So by Priority Consult guidelines, we are collecting data on both surgical and non-surgical patients at the recommended intervals that you see listed here. Okay, so how do we explain to patients the importance of outcomes and try to get them to return them? And first of all, we ultimately decided to mail our outcomes to our patients, and I will speak a little bit more about that in a minute. But what we decided to do is, after we finished an intake, we had a script that you can read, but it basically just tells the patient that they could expect to receive a mailing that not only had more information about the spine center, but also had a survey that we would like them to return. And we also included a self-addressed stamped envelope to make it easier for them. And at that time, we also would remind them that they could expect to receive these surveys periodically over the next 2 years. And I think people really do like that. You know, with today's healthcare, sometimes I feel people think they get lost in the shuffle, and so when you tell them that you're actually somebody that's going to be checking on them for 2 years, they do seem to like that. And so this is an example of a letter that would have gone in with a patient after we finished an intake, explaining the surveys and explaining that they come in periodically. And the next slide is a similar one that shows the letter for a surgical patient. And as most of you know, Priority Consult does provide these templates, and you can customize them to more or less towards your spine center. So it makes it very easy once you finish an intake to just go ahead and print that letter out along with your outcome surveys and stick them in the mail. Okay, so our initial challenges, I felt, were many. To begin with, I knew nothing about collecting data. So Natalie, my spine intake specialist, and I at first thought the best way to do this so that we wouldn't forget would be to try to get the data over the phone after we completed an intake. And that, within just a few intakes, we realized that was almost impossible. It was very time-consuming and very confusing for the patients. And so for those of you who are already using, for example, the Oswestry survey, and those of you who may have just seen it for the first time during Holly's presentation, you can tell that there's a lot of choices for patients to decide what fits them best. And so, we found a lot of times that we had, patients stopping us and asking us to repeat each option, and, they just couldn't visualize it. So that's when we decided we would definitely mail our surveys. And like many medical hospitals, the things don't move quickly, and so when we needed self-addressed stamped envelopes, that took about 6 weeks for us to obtain. So in the meantime, Natalie, my intake specialist, and I were alternating buying the stamps until we could get our self-addressed stamped envelopes. Another big thing when you first start out with this is just remembering to enable the outcomes so that they'll automatically start to be tracked in Priority Consult. We ultimately decided that that would be the first thing we did after we finished the intake, would be that we had enabled them and then actually printed the surveys and put them in the mail. And I've just had a recent experience in that Natalie, my intake specialist, left me a couple of weeks ago to pursue a physician's assistant school, and I have a new employee that I'm training right now, and this whole thing has gone much more smoothly than when we were trying to develop it, because I think we already had a good method in place, and so all I've had to do is just teach the new employee that enabling the outcomes is the first thing she does after she does an intake. So I think most of you might find that too whenever you have a new employee, if you have a good method in place already. So our current challenges are, like I said, we're a very new spine center, and there are just 2 staff members, me and my intake specialist. And so there's a lot to get done and be responsible for with these patients with just 2 people. And so most of you can realize this, that as your referrals increase, getting the outcomes mailed out increases exponentially. So right now, not only are we sending out initial outcomes for intakes that we have just done, but we're also having to go ahead and start working on our 3-month outcomes that need to be mailed out. And so that is difficult. We have talked with administration about possibly getting a hospital volunteer that comes in a day or 2 a week to just to get these mailings for us, because when 6 months comes around, it's going to get even more difficult. Another kind of strange situation that's maybe unique to us is that our medical director, who is an orthopedic spine surgeon, isn't quite on board with this whole concept and is a little bit hesitant to send his patients through the spine center for triage. Yet he wants us to collect outcomes on any of his patients having surgery. So he's seeing the patients in the office, setting them up for surgery, and then sending them to us for outcomes. And so this has been a kind of a battle, because those of you who do this know that that's a lot of work when you're not really getting credit for the patient being sent through your center. And so administration is working with us on that. We also need to continue to work on increasing our response rates. Even though I am really, really amazed at how many people return the surveys, we're still nowhere near that 85% that's desirable right now. But I am, like I said, very pleased with the people that are returning them. I know I'm the world's worst at completing surveys when they're sent to me. So I don't know if it has something to do with the fact that we're in Western North Carolina, kind of in a retirement community, and many of our patients are elderly and not working, so maybe they do have the time to do this. But we will still try to work on that. And then also, as I kind of alluded to with our medical director not sending us many of his referrals, we do have a low number of actual surgical patients that have come through the spine center. And since we're only using the THQ-9 survey for surgical patients, I do have a tough time remembering to send out that survey when I find out a patient is having surgery. Okay, and this is an example of some of our current data on non-surgical patients who have filled out an OSWESTRI or an NDI survey. And as you can tell, you know, our initial or baseline is low compared to what is desired. But we're still on the trend that Holly was talking about, that when you look at the 3-month rate, it is much less than what it was at baseline. And then this is an example of our surgical data, which looks much better, more towards that 85% rate that we all want. But you can also see the very low number of surgeries that we've had that probably accounts for that as well. And so for us in the future, I know, as I mentioned at the beginning, the hospital really wanted to push us collecting outcomes for the reasons that this slide says and that Holly mentioned. But we do hope to use it for accreditation, to fulfill payer requirements, and for marketing purposes. And as we go along, I do see that we will need to either have an extra person on hand or give me more time to analyze this data, because I know it is going to be expected with the hospital in the future. Because if you're collecting data that don't really have the information it provides, then it's not very useful. So I hope anybody out there gained some information from this, and I very much appreciate you attending.
Again, we would like to thank everyone for attending the webinar. If there are any questions that anybody has about the presentation, you can email us at education@priorityconsult.com, and we would be happy to answer your questions. So again, thank you, and we hope to hear from you all. Thanks.